I'm Evelyn Son. I'm one of the third-year fellow and chief fellow leading cardiology grand rounds this year. So it's my great pleasure to introduce Dr. Marko Boskovski today, who's our speaker for grand rounds. Dr. Boskovski is an assistant professor of surgery at UCSF and director of Ross and aortic valve preserving surgery. He completed medical school at Yale School of Medicine, general surgery residency, and cardiothoracic fellowship at Brigham and Women's Hospital. He specializes in complex surgery of the thoracic aorta and has a special interest in aortic root surgery, including the Ross procedure, valve sparing, aortic root replacement, and aortic valve repair. His research focuses on the biomechanics and genetics of diseases affecting the thoracic aorta and surgeries like the Ross procedure. And today he will be talking to us about the proximal thoracic aorta disease and the recent guideline updates. So without further ado, thank you, Dr. Boskovski.
All right, thank you, Evelyn, for that kind introduction. And thank you for having me today. So the last time I gave grand rounds in this forum, we talked about the Ross procedure and the aortic valve repair. So I thought this time around we'll move one step distal to that. So we're going to talk about the proximal thoracic aorta. And I think this is a very timely talk in the sense that we have new guidelines, both from the ACC/AHA, the so-called American guidelines, and also the EACTS/STS guidelines, or the so-called European guidelines that were published in 2022 and 2024. So, as these guidelines typically go, it's pretty light reading. One is 150 pages and the other one is 99 pages. This is reflective, obviously, of the ever-increasing complexity of aortic disease and what we do to manage this. So we'll try to go through some of these guidelines as they relate. Before I go any further, I should say that our very own Elaine Singh was part of the ACC/AHA writing guidelines. And she's really the expert here. I just work here, but it has been a privilege to be able to pick her brain as I've kind of looked through these guidelines and I've studied them as to what the writing committee really meant and what the discussions were behind closed doors. So there's some interesting things that I've learned along the way. So that has been quite interesting. Unfortunately, she is out of town in Europe, so she won't be able to join us today. So the guidelines, really, they're very comprehensive, and they were developed in collaboration with and endorsed by a number of organizations, not just cardiology and cardiac surgery, but other fields that play an integral part in treating aortic disease, such as radiology, anesthesiology, vascular surgery, among others. So this is an important document for sure. And it is important to sort of know how we got here. And, the first guidelines were published in 2010, the first aortic guidelines. And over the years, there's been quite a few guidelines that have made recommendations for aortic disease. Not all of these are aortic guidelines. A lot of them are actually valvular guidelines. And that, of course, makes sense because the aortic root encompasses the aortic valve, and it's a living structure. And it's very difficult to separate the two. But the latest guidelines certainly try to stay in line with prior guidelines as they relate to the aorta. So what are we going to talk about today? Well, we're just going to talk about the proximal thoracic aorta. I think that's plenty to cover. I think that is also probably what is most relevant to the practicing cardiologist. So we're going to talk about the aortic root. We're going to talk about the ascending aorta. Mostly sporadic disease, but we will touch on some of the syndromic aortopathies as well. We're not going to talk about the arch, the descending, certainly not going to talk about the abdominal aorta, which I do not practice. And we're not going to talk about a favorite field of mine, which is aortic dissection, perhaps another time. So there's a lot of details that we'll get into, but before we get into the nitty-gritty, it is good to step back and go back to the basics. What's the problem? How do we identify it? And how do we fix it? So the problem is that the aorta can dissect or rupture. That's bad. When you rupture, usually that's uniformly fatal. If you dissect, if it's a type A dissection, 50% of those patients don't make it to the hospital. Even those that do make it to the hospital and have a repair, operative repair in modern series, still 20 to 25% mortality. And even if you survive a repair, the long-term survival of these patients is actually quite poor. So the name of the game really is to prevent a devastating complication as it relates to aortic disease. And in order to do that, the first thing really we have to do is, well, we have to know how to identify diseased aortas. We're going to talk about the definitions of aortic dilation and aneurysms, how we image them, and there's a lot of nuances that go into this. A lot of this gets brought up every week when we have multidisciplinary heart team discussions. And finally, we'll talk about some of the fixes. I put medicine in a very small font, not because I'm a surgeon, but because really our medical therapies for aortic disease are limited. I'm going to talk about them, but for the most part, we look at medical therapy as best as we can, surveillance, and then once you get to a point where the aorta, it may have complications, we think about surgery, and I'm going to talk about that. So when does dissection or rupture occur? I think this is actually a very important concept to briefly go over. And really what we're looking for is to identify the point where wall stress becomes greater than wall strength. And that's when you get an intimal tear. That's when you get a dissection. That's when you get a rupture. So we'll talk about diameters and other indices and this and that. But at the end of the day, really, what we want to know is what is the wall stress on this aorta? And the holy grail, hopefully, one day we'll get there, of aortic imaging, is that we will be able to create a heat map of the entire aorta, what the wall stresses are like, what the strength of the wall is, perhaps based on how thick it is and what the distensibility of the aorta is. We're definitely not there yet. This is some of the research work of Elaine Singh, actually, but that's the holy grail. That's what we really want. And when we talk about the guidelines, the different cutoffs, it's important to keep in mind that really the various diameters and this and that, they're all proxies for wall stress. Of course, diameter plays into it. The shape of the aorta plays into it as well. Patient's blood pressure, other factors go into it as well. So, okay. So what is a diseased aorta? So in order to answer this question, we have to look at some studies that have looked at the natural history of diseased aortas. This is an older study from University of Toronto, Tyrone David's group, and they looked at patients that had bicuspid aortic valve that had undergone isolated aortic valve replacement, and then they followed them over time. They segregated them based on different aortic sizes, and it's pretty clear that once you get those patients that had an aorta that was 4.5 centimeters or more at the time of surgery, they had quite a few aortic complications over time. So certainly 4.5 centimeter aorta is an abnormal aorta. Even if you look at the 4 centimeter aortas, those had worse outcomes as well. This is a study from John Eleftheriadis from Yale, actually contributed a tremendous amount to the field of aortic disease. Here they looked at the MESA database, or the multi-ethnic study of atherosclerosis. They looked at adults that did not have overt cardiovascular disease. And they took those patients or those subjects that had chest MRIs, then measured all the aortas, and as can be expected, there's a normal distribution of aortic sizes in the thoracic aorta. So what they were particularly interested was really the outliers on the right. And if you take the top two, if you go 2 standard deviations above normal, that's when you get into the 4 to 4.4 centimeter aortas. And if you're 3 standard deviations above normal, if you're in the top 0.2 percentile, that's when you have an aorta that's greater than 4.5. So certainly you're in the abnormal range once you get into the 4 centimeter and above. So the way the guidelines, and before I actually get into that, so then what they did is they took that data and they superimposed it and combined it with data from the IRAD database, or the International Registry of Aortic Dissections, to estimate what the risk of dissection is based on size. And if you're at 4 centimeters, there's an 89-fold increase risk of dissection. Of course, this is relative risk. And once you get to 4.5 centimeters, there's a 6,300-fold increased risk of dissection compared to a normal aorta. So certainly once you get into the 4s, that's an abnormal aorta. And the way the guidelines sort of recommend that we refer to these aortas is if you're in the 4 to 4.4 range, it's aortic dilation. The reason being is that once you label somebody as having an aneurysm, there's a lot of anxiety and stress that comes along with that. So we reserve that term if your aorta is 4.5 centimeters or more. So now that we know what dilated and aneurysmal aorta is, we have to talk about imaging, because the second problem with aortic disease is that by and large, it's asymptomatic. I mean, certainly if you have symptoms, that's typically an indication for urgent repair, sometimes a sign of impending rupture. But for the most part, it's asymptomatic. So we essentially have to purely rely on imaging in order to diagnose it and to follow it over time. Many different imaging modalities. We primarily rely on echo, CAT scans, as well as MRIs. Transthoracic echo is super helpful. You know, we do it all the time. We have excellent echocardiographers, and in expert hands, there's actually very good correlation between the measurements done with echo and those measurements in CAT scans. I think the issue that we run into is that oftentimes there is user variability, especially from the community. Just last week, I saw a patient who was had an echo that was read as having a 5-centimeter aneurysm that ended up being 3.9 centimeters on a CAT scan. So there is, you know, it is user dependent for sure. There is also some controversy over how exactly these measurements should be made. So historically, we've done leading edge to leading edge measurements. This is sort of a byproduct of initially using M mode to look at these measurements. But if you think about it from a physiologic standpoint, it actually doesn't make a lot of sense. And there's been a recent push to also do inner edge measurements that also correlate well with CAT scan measurements. And the guidelines do talk about this, and there is still a 2A recommendation for leading edge to leading edge measurements, but they do think that it's reasonable to also do an inner edge to inner edge measurements. Once we know that we have an aneurysm, or if we want to accurately measure it, really we're looking at CAT scans. And there's a few technical aspects that are worth going over because they can significantly impact your measurements and what you end up doing. These relate to IV contrast, using orthogonal measurements, inner edge versus outer edge measurements, EKG gating, super important, especially if you get down to the root. And we talk about the root measurement because the root, of course, is not circular, it's cloverleaf, or it can have other shapes as well in bicuspid valves. So this is what a CAT scan looks without IV contrast. It's just a blur of gray. It can be very difficult to discern the aorta, but actually, if you do 3D orthogonal reconstructions, you will oftentimes get a pretty good idea, actually, of what kind of an aorta you're dealing with. And we do have a number of patients with aortic disease that we're following with non-contrast scans if they have kidney disease or other issues, contrast allergies and whatnot. But really, ideally, you would have contrast, right? Because it's just so much easier. You're able to delineate the blood vessel. And it's a different, it's just much easier to measure. In general, a non-contrast scan will overestimate your measurements anywhere from 2 to 4 millimeters. And it just has to do with the fact that you're measuring not just the inner to inner surface, but you're measuring the whole wall of the aorta. Talking about the different planes that we can measure this in, if you open up a CAT scan, it will come in sort of the standard axial, coronal, sagittal views. We used to use the coronal views quite frequently to measure the ascending aorta. You can also use an axial view, but nowadays, especially really with modern TAVR measurements, centerline measurements, there's really no excuse not to do orthogonal reconstructions. You really want your plane to be perpendicular to the sort of idealized direction of blood flow in order to get a perfectly perpendicular and accurate measurement. And now there's this question of, well, should you do the inner edge to inner edge measurement, or should you do the outer edge to outer edge measurement? So this is, I just took a patient that I recently saw. If you do the inner edge measurement, it's a 5.1 centimeter. But then if you do an outer edge measurement, shazam, all of a sudden it's a 5.4 centimeter. It's kind of a big difference. And to make things even more confusing, if you look at the American guidelines that will say you should use inner edge, class 1 recommendation, unless if there is significant disease in the wall, in which case you should switch to outer edge diameter. And then we have the European guidelines, which, by the way, the STS is our own American association. That's in the name of these guidelines. They argue for an outer edge measurement all the time because a lot of times these aortas are diseased. So there's a lot of controversy. I think probably what's more important, first, we should remember the basics, right? Like the diameter is just an estimate of wall stress. And probably what's more important is one, to be consistent in what you do. And two, whatever measurement you do get, to ultimately put it in the context of the patient, because that's probably more important at the end. Now, EKG gating becomes very important the closer you are to the heart. The heart moves throughout the cardiac cycle, and if you don't gate, you get this. I mean, where's the edge here? Is it here? Is it this line here? Is it this line here? It's hard to tell. You can't really measure it accurately. So you need to have appropriate ECG gating to get a nice image such as this one, so you can do appropriate measurements. I didn't put a slide here. It also matters which phase of the gating you're in. Are you going to be in the systolic phase, or are you going to be in the diastolic phase? Obviously, the systolic phase will be bigger, sometimes by several millimeters. That's probably what's most physiologically relevant, but oftentimes the scans are gated in a diastolic phase. So that's just something also to be mindful of when you look at these scans. And then this question about how to measure the aortic root. If you look at radiology reports on what's historically been done most commonly, we've done commissure to sinus measurements. Certainly they look very pretty, they're symmetric, but the issue is, if you kind of think about what we're trying to accomplish here, which is to measure a proxy for wall stress, it actually makes more sense to do maximal sinus to sinus measurements. And this is addressed in the guidelines as well, that you should really, as a class 1 recommendation, you should do maximum sinus to sinus measurements. We have been working with our radiology colleagues, and I think now all of our TAVR CTAs have sinus to sinus measurements as well. Well, the regular CTAs still don't, but hopefully we'll fix that in the near future. And then once you get to bicuspid valves, I mean, how do you measure a commissure to sinus, on this? It's really not possible. So you have to do a sinus to sinus measurement in those cases. Okay, so now that we know how to diagnose these aneurysms, we'll talk a little bit about the treatment, and we'll talk about medicine first. At the basic level, medical treatment essentially boils down to good blood pressure control. The aorta sees whatever blood pressure you have. You have a blood pressure of 200, that's what, it's going to be more force in the aorta. So it is important to have good blood pressure control. And the treatment modalities are beta blockers, angiotensin receptor blockers, and then statins may also have a role. This is now a 30-year-old study that was published in the New England Journal, where they looked at the effect of beta blockers in Marfan's patients. And it was pretty clear that if you treated Marfan's patients with beta blockers, one, their aortas grew at a slower pace, and two, they actually had fewer dissections and less aortic surgery. So I think that was pretty clear. Now, what about trials that look at beta blockers in aneurysms of other etiology? Well, there are none. So all of our data is extrapolated mostly from patients with connective tissue disease, and it's unlikely that we will have trials in the future. Now, what about angiotensin receptor blockers? They work really, really well in mice. This is a science paper that was published in 2006, where you have a normal wild type aorta. This is the Marfan model, clearly diseased. Propranolol does reverse the phenotype some, but this is still not a normal wall. But if you give these mice losartan from an early age, you actually prevent Marfan aortopathy. The problem is it doesn't work as well in humans. Unfortunately, we're not quite the same as mice. Here, this was a study from the Pediatric Heart Network, where they randomized patients to either atenolol or losartan that were followed over 3 years with echo measurements of their aortic root, and there was no difference between the two. I guess from a good perspective, it was as effective as beta blockers, but not as promising as some had hoped it would be. This study that I just showed from the PHN had a 3-year follow-up. This is a similar study with a longer follow-up. Again, no difference between beta blockers and ARBs. Now, if you have blood pressure room, there is some data to suggest that if you combine the two, they do better than beta blockers alone. So certainly that's something to consider. What about statins? Well, we know that there is excess MMP9 activity in ascending aortic aneurysms in the wall. And we also know that statins reduce MMP9 activity. So it sort of makes sense that they may be beneficial in this patient population. There are retrospective studies that have shown an association This is a study from the Cleveland Clinic. They looked at patients with bicuspid aortic valves who underwent AVR. And they looked to see, were these patients on a statin for whatever reason or not? And as it turns out, those that were on a statin had aortas on average that were 3 millimeters smaller than those that were not, suggesting that there may be some beneficial effect of being on a statin. A very similar study from Northwestern, again, bicuspid patients that were undergoing cardiac surgery. They set up the study slightly differently in that they divided the cohorts to those that had aortas greater than 4.5 centimeters and less than 4.5 centimeters. And if you had an aneurysmal aorta that was bigger size, you were much less likely to be on a statin, again, showing the same correlation. And finally, going back to Yale, John Aleshariadis' group, they also looked at the correlation between statin and aortic complications. You would assume that if a patient was on a statin that they had cardiovascular disease, that perhaps they would actually have worse outcome over time. But those patients actually did better, had better survival or freedom from aortic dissection over time, suggesting that statins may be beneficial. So what did the guidelines say? Well, as I mentioned, makes sense to have good blood pressure control, ideally less than 130/80. Recommendation to use either beta blockers or ARBs, or combine the two if you have blood pressure room. And certainly if you have either clinical or imaging evidence of atherosclerosis, I mean, you would probably treat those patients with statins anyways. And then there's a class 2B recommendation to use statins even in patients who do not have atherosclerosis. And that concludes our armamentarium for medical treatment of aortic aneurysms. So then we get into surgery. And before we start talking about the various cutoffs, good to talk about the basics again. So elective aortic surgery is purely prophylactic. And I put a little asterisk there because I will show some preliminary there that there may actually be some therapeutic effects. But in general, when I talk to patients about this, the goal of the operation is to get them back to exactly where they were before the operation, but eliminate the aneurysm, hopefully eliminate the risk of rupture or dissection. So if you have any given patient and they have a certain surgical risk, you know, what we're essentially trying to do is figure out when do these risk lines cross. So you do surgery when the surgical risk is lower than the risk of rupture and dissection. And really, you're trying to do the lowest risk thing possible. So just because a patient may have an aorta that's 5.6 centimeters, if they're a poor surgical candidate, you may still not elect to operate on it because you're trying to do the safest thing possible at the end of the day. So here we are. Busy slide. We'll go over this. So just to orient folks, so I've organized it by either tricuspid valves or bicuspid valves. This is for sporadic aneurysm, so not familial, not syndromic, where the primary indication for intervention is the aorta, right? And these are the first guidelines in 2010 and onwards. As I said, there's been a lot of them. And then on the right here, we have the most recent guidelines. But as you will see, this 5.5 number is all over the place. Well, how did we even start with this? So it all goes back to the late 90s to John Aleshariadis and Yale. So this was the original Yale cohort, 230 patients. They followed them over time and they looked to see if they had aortic complications. And they found a dramatic increase in risk at about 5.75 centimeters. And it made sense to intervene before you reach that size threshold. So 5.5 was the suggested cutoff. And that was used in the 2010 guidelines and then was then kind of propagated in subsequent guidelines. But as time went on, new studies were published and some issues came to light. Well, this is the IRAD database, almost 600 type A dissections, mostly sporadic, very few Marfans, very few bicuspids. And the issue is if you look at all the dissections in this cohort, 60% of them were under 5.5 centimeters. They would have never gotten offered surgery, right? So Houston, we have a problem. I mean, this is not good. And then even if you look at 5.0 centimeters, 40% of the sections were less than that cutoff. So this was the first time they would start thinking, well, maybe this 5.5 centimeter cutoff is too high. And also, again, as I said, what we're after is not diameter, we're after wall stress. And the correlation between wall stress and diameter is actually relatively poor. And I think some of this data is just a reflection of that fact. So the Yale group went back more recently. They have an updated cohort, more patients. And as it turns out, there's actually two hinge points. There's the original 5.75 centimeter hinge point, and then there is a smaller hinge point of 5.25 centimeters that has in part driven the so-called leftward shift in the thresholds from 5.5 centimeters to 5.0 centimeters. But in order to kind of figure out when we should operate on these patients, we have to talk about surgical risk. Because if you're going to offer surgery at a lower cutoff, you really need to be able to justify it, ideally with a lower surgical risk. So there's been a lot of that's actually been published on this. And as has been the case for a lot of different procedures, the more aortic surgery you do, the better you are. This is a study from Chad Hughes that he looked at the STS database where most American hospitals report their outcomes in cardiac surgery. And what they showed is that if an institution does about 30 to 40 aortic operations per year, you, one, significantly decrease the operative risk, and two, you reach this plateau. There's an updated version of this analysis, Arne Gerson from Yale and his group. And again, similar findings. In red is the operative mortality. So if you do very few cases, operative mortality is fairly high at 5%. But if you get to greater than 50 cases, then your operative mortality is down to 2%, less than what's expected. And then, the table on the left, the analysis is really for institutions. But if you combine a high volume aortic institution with an aortic surgeon, then you can drop the mortality down to 1%. And this is data from the Cleveland Clinic. So certainly experience matters. What is actually quite fascinating from the STS analysis is that the vast majority of centers in the United States do less than 5 aortic operations per year, right? So there's very few centers that do a lot of aortic surgery. And once you get greater than 50 cases, well, then there's only 24 centers in the whole country that do more than 50. And where do we fall? So these are our most recent numbers in the last few years. So last year we did 63. This year we're projected to do 72. I'm actually quite confident that as we're building our aortic programs, both on the cardiac surgery side and the cardiology side, that we're gonna do upwards of 100 cases very soon. So that's where we stand in terms of operative risk. The other risk that we have to talk about, well, what is the actual risk of having aortic complication at any given size? Two very informative papers, one from the MGH and one actually from Kaiser, Northern California, just down the street. Similar numbers of patients, around 5,000 patients, 6,000 for the Kaiser group, non-syndromic patients, 11 to 12% bicuspid follow-up of 3.5 years. And what you will see is that once you get to 5.5 centimeters, your risk over 5 years of having an aortic complication, rupture, or dissection is anywhere from 3% to 8% if your aneurysm grows. So certainly the 5.5, the more conservative cutoff, makes sense in light of this data. Now, if you're going to offer earlier surgery at a 5 centimeter cutoff, it still makes sense if you do it at low operative mortality, because the risk of rupture dissection is as low as 1.1% from the MGH data, and then as high as 3% if you have an aneurysm that's growing from the Kaiser data. So it makes sense, but it has to be done in the right context. And this is codified in the guidelines as that 2A recommendation that if you have stable aortic disease, it makes sense to get referred to a high volume center, which they've mentioned is 30 to 40 cases annually, to get treated by an experienced aortic team. All right, so we see here class 1 recommendation of 5.5 centimeters, 5 centimeters if you're being treated by an experienced team. What are the other measurements that we can use? And these are also in the guidelines, most of them are indexed to patient height or BSA. And the most commonly used one is cross-sectional area over height ratio. There is also the aortic size index and the aortic height index, which have been published by the Yale group, but we'll go over this data. So this data comes from the Cleveland Clinic. They looked at their own patients, and there's two separate analyses for tricuspid and bicuspid patients. They separated patients by those that had an aortic root aneurysm. So if you had a cross-sectional area over height ratio greater than 10, and you did not have surgery, you had really poor outcomes. This is freedom from death. But if you had an operation, you had essentially the same outcome as those that did not have a high ratio. And interestingly, if your ratio was below 10, well, then it actually didn't matter whether you got surgery or not, your outcome was the same. So that seemed to be actually a very sensitive and specific cutoff. Similar analysis for the ascending aorta, although if you notice, the root phenotype seems to be slightly more malignant, and that's something that comes out in the guidelines as well. And then they repeated the analysis in bicuspid patients, and the findings are very much the same. If your cross-sectional area over height is greater than 10 centimeters, you really should have surgery because the outcomes are quite poor if you don't get that repaired. And that's codified as a class 2A recommendation. It's important to realize this is Cleveland Clinic data, right? So that's potentially the highest volume center, one of the highest volume aortic centers in the country and in the world. So if you're going to use this cutoff, you really have to be a high volume center. It is not meant to be used otherwise. What are the other indications for tricuspid valves? Well, there's a growth rate indication. So if you have an aorta that's growing quickly, that's a back prognostic sign. You can either grow 0.5 centimeters per year for 1 year or 0.3 centimeters for 2 years. So that's a class 1 recommendation. And finally, what if you're getting cardiac surgery done for other reasons? So if the primary indication is an aortic valve operation, then it makes sense to intervene on the aorta if it's 5 centimeters or 4.5 centimeters if it's done in a high volume institution. But the interesting thing is that, and this is something that Lane clarified for me, it's really for aortic valve procedures. So if you have a cabbage, actually, they do not comment on it. So presumably you would leave an aorta alone, although I think in practice a lot of times surgeons would tackle those as well. Now, what about bicuspid aortopathy? This actually comes up all the time in conferences. Do these patients have a higher risk, lower risk? What's going on? And if you look at the guidelines, busy slide again, but what you will notice is when we first started off in the 2010s, the recommendation was to treat these patients at a size of 5.0. And if you read the text, they clumped them together with Marfan's, Ehlers-Danlos, Loeys-Dietz. So it was considered to be a genetic aortopathy, and that's why there was a cutoff of 5.0 centimeters. There was a clarification in 2016 that really suggested that we should not treat bicuspid patients differently from tricuspid patients. And if you look at the recommendations today, the cutoffs are essentially the same, right? And well, why is that the case? So there's some interesting data around this. So this is from the Mayo Clinic. They looked at their type A dissections. They looked at all of their bicuspid type A dissections from 1980 to 2010. They paired it with 53 consecutive tricuspid patients. And interestingly enough, the bicuspid patients dissected at a full centimeter larger size of the aorta than the tricuspid patients, suggesting that perhaps it's not a more malignant phenotype as we had originally thought. And this is an analysis, again, from the Yale group that looked at the relative hazard of adverse aortic events. And there is a suggestion, again, that perhaps even tricuspid aortic valves that have aneurysmal aortas have a higher risk than bicuspid ones. Certainly not the other way around. And just as convincingly, if you look at the biomechanical data, where they took patient samples with bicuspid aortic valves and aneurysms and tricuspid valves, the bicuspid valves actually had greater strength and it required more stress for failure. These are two studies that show this. So where do we stand? I think that the issue is that all of this data is retrospective. And as a community, we have changed the natural history of bicuspid aortopathy because we've operated on a lot more bicuspid patients. So going back to the Kaiser study that I showed earlier, in that study, they had overall 11% bicuspid patients. Okay, so these are the different bicuspid proportions based on aortic size. But now look at the intervention rate. So if you had a aneurysm that was 4.5 to 4.9, overall, the intervention rate was 18%, but in the bicuspid group, it was 50%. If you go one size up, 40 versus 70%, et cetera, et cetera. So we have essentially eliminated a significant portion of risk in bicuspid patients because we intervene on them much earlier, even though some of the data was just, that's not warranted. So in the text, they say overall aortic dissection events were quite rare in patients with bicuspid aortic valves. Only 1 out of 44 in that whole cohort were in a bicuspid patient. But of course, a lot of their bicuspid patients have already gotten surgery. So it's very hard to tease apart from retrospective data whether these two cohorts are different or not. So where do we stand in terms of the recommendations? So the class 1 recommendation is 5.5 centimeters. Class 2 recommendation for 5 centimeters if you are at a high volume center, if you have a family history of dissection. I'm not going to get into the data, but the root phenotype is thought to be a higher risk phenotype. So if you have a root aneurysm, it makes sense to operate at 5 centimeters, especially if you can preserve the native aortic valve. And then there is a class 2B recommendation if you're at a high volume center without any risk factors. Now, very briefly, what about syndromic aortopathies? This is probably it takes up a great portion of the guidelines. It deserves its own talk, but for, as a general principle, if the patient has a weaker aorta that's going to dissect at a smaller size, it makes sense to intervene at an earlier stage. And that's reflected for Marfan patients, where if you don't have high-risk features, the recommendation is 5 centimeters. If you do have high-risk features, the recommendation is 4.5 centimeters. And then if you look at Loeys-Dietz, we've gotten actually very granular and depends exactly on which variant you have. And the range can be anywhere from 4 centimeters to 4.5 centimeters to 5 centimeters, depending on the genetic analysis. Now, speaking of the different genetic syndromes, how and when should you screen? This is actually pretty straightforward. If you think that they have genetic syndromic features, it makes sense to do screening, right? If it runs in the family, it makes sense to do screening. If you're very young being defined as less than 6 years of age, it makes sense to screen because those patients are more likely to have a genetic cause for their aneurysm. And then finally, if you have a patient who you think has sporadic disease, you screen first-degree relatives, usually with a transthoracic echo, and you find that they have aortic disease. Well, they're not sporadic anymore, then they're familial and they should get screened as well. Another critical aspect is how to follow these patients, and the guidelines are actually fairly vague on this point, and I think this is on purpose because there are so many nuances and individual details for each patient. It's very difficult to codify a specific surveillance regimen in the guidelines. But as a general rule, I think if you see a patient with aortic disease, the first thing that you have to figure out is this growing or not? So usually we'll do a scan around 6 months, a surveillance scan to see whether the aneurysm is stable. And then going from there, the approach that we take is that it really depends on how far away you are from potential intervention. If you are within a few millimeters of intervention, it makes sense to scan every 6 months to a year. If you are 3, 5, 6 millimeters away, usually we do annual scans. And if you're more than that, we will often scan every 2 years. If you're not close to an intervention range, especially if you're young, we will switch over to cardiac MRIs. It takes longer and the resolution is not quite as good as CAT scans, but I think it's quite informative and you save them a lot of radiation, especially if you have to do it over a long period of time. So let's talk very briefly about the future. So these are all this is a summary of both the tricuspid and the bicuspid recommendations. I can send these, by the way, to folks if they wanted to put on their phone, so you don't have to read the whole guidelines. But anyone notice a problem with this slide? Evelyn, you see any problems here? So if you look at the level of evidence, there's 0 level of evidence A. Okay, so everything we just talked about, it's all retrospective, it's all extrapolation, surgical risk from this study, dissection risk from that study. Maybe if we put them together, it's all retrospective, right? It's a huge problem. So that's going to change. There is an ongoing trial. It's called the Titan trial. We're part of it. Elaine and I are the site co-PIs. Munir Badwani from Ottawa is the main PI for the whole trial. It looks at aneurysms that are 5 to 5.4 centimeters, and you randomize patients to either surgery or active surveillance. So they have to have root or ascending involvement. They have to be adults between 18 and 80 years of age. Excludes any genetic or familial aneurysms. It can be either bicuspid or tricuspid, and the primary outcome is 2-year all-cause mortality or aortic dissection. We've actually randomized 8 patients, and we've enrolled another 3 in the registry. It is quite difficult to randomize somebody to surgery, major aortic surgery, or nothing. So I'm always amazed when patients sign up for this, but I think that this will be a very informative trial. So I briefly want to show some preliminary data that Munir shared with me. This is from the registry. And I mentioned that elective aortic surgery is, for the most part, prophylactic. This would actually argue otherwise. So between May of 2019, December of 2022, 22 patients went into the registry, so these were not randomized. And then about 157 patients completed a questionnaire on both their physical and mental health and state. And then about 50 underwent surgery and 100 are still in surveillance. So the way this questionnaire works is that the closer you are to the center, the more negative you are, the worse it is. And the mental components are on the left, and then the physical ones are on the right. Check this out. So the patients who had surgery reported significantly better mental health, emotional limitations, social functioning, etc. As a good control, bodily pain was about the same. I guess perhaps there could be more bodily pain with surgery, but there wasn't. But also, they were able to do more. So I think perhaps I have underestimated how difficult it is to live with an aortic aneurysm, because you really do consciously or subconsciously fear that there may be a complication. You limit what you do, and you certainly don't feel as well. So you will see what the randomized data will show, but at least in the registry data, there is a suggestion that there may be a therapeutic benefit to aortic surgery as well. So again, this is a detailed summary of the latest guidelines. I'm happy to share them. Sort of the broad and oversimplified summary is that 5.5 centimeters is still the standard threshold no matter where you are. There are various features that will drop your threshold to 5.0 centimeters, especially at high volume centers. Bicuspid recommendations are similar to tricuspid. That's not to say that they're the same, but that's what the recommendations say. And I didn't show a lot of data, but the root phenotype, especially in bicuspid patients, tends to be worse than in the ascending, and randomized data is coming. And I think once we have data from the Titan trial, that will may potentially dramatically change the way we look at aortic disease, and will probably be time to write another set of guidelines. Thank you.
Thank you, Dr. Boskovski. That was a great talk. So now we'll open it up for questions. And people on Zoom, if you have a question, feel free to raise your hand and then unmute. And then people in person, okay, start here.
Hey, Marko, great talk. Just a comment and then maybe a question about our practice here. So as you mentioned, certainly echo is the gateway for a lot of these patients. And the guidelines looking at leading edge to leading edge or inner edge to inner edge. My understanding is the reason that they've sort of kept the leading edge to leading edge is those numbers tend to be bigger, and they certainly didn't want to bias people towards smaller aortic measurements. But you presented a lot of data on CT, and there are a number of patients who get CTs for other reasons, they're non-gated or whatever, and then a measurement is made, or even the ones that we get here. And some of the additional measurements you described, certainly looking at the area to height, those aren't reported consistently. What are sort of the measures that we're starting to take here to report measurements that may be more useful to help us make decisions for these patients?
Yeah, so it's a great question. I mean, again, at the end of the day, we want the wall stress. We don't have the wall stress. The diameters are reported. I think where the index measurements become very helpful is if you have patients who are not average size. And I think a lot of times in those settings, it is helpful to measure the area over height or size over height index measurements. So we have started to, in our clinic, sort of to routinely measure all of the measurements for all patients that appear to be close to a potential surgical range. Because I do think that the Cleveland Clinic data on area over height over 10 is quite robust in discriminating patients that need intervention. And I think that's probably, with the data that we have now, that's probably the most helpful.
And I see both Nora and Jaya have a question on Zoom. We'll start with Nora, and then Jaya ask the question, and we can see you on Zoom here in person as well.
Okay, thank you so much. And Marko, just a wonderful, wonderful talk. I have one practical question and one theoretical question. How do you do ECG gating in atrial defibrillators, number one? And number two, what are your thoughts about the effect of statins that might work? And could it be their anti-inflammatory component? And what about the role of inflammation in this whole thing? Right.
Well, so I'm not a radiographer, so I'm gonna defer the answer on how to gate on AFib. But certainly, I would imagine that there would be a way to retrospectively gate, although maybe a little bit time-consuming and challenging. And then in terms of the statins, I mean, I think that is the leading hypothesis, that it is some of the anti-inflammatory effects of the statins that may be beneficial. I think our understanding of how inflammation drives aneurysms is very incomplete. And it's pretty clear that, people start off with a normal aorta, and then there is an event that leads typically to rapid growth. Most of the time, we don't catch that rapid growth, and then they settle out at a new, larger size, and we follow them over time. They tend to grow most of the time relatively slowly. What that inciting event is, whether it's some sort of like an inflammatory episode, is it virally driven? I mean, we don't really understand that at all, or not that well.
Do you think it's standard practice to use them, the statins? Is it standard practice at this point?
I think that a lot of people will use a statin, especially because there's such a big overlap in patients who have aortic disease, who have atherosclerosis. It makes sense. Okay. I am curious what folks here do in, let's say, younger patients who don't have evidence of atherosclerosis, whether they put them on statins or not. That there's probably more variability in that patient population.
Thank you.
All right, Jaya, are you still on Zoom?
Yeah. Marko, thank you so much for the talk. I learned a lot. I was wondering if you could tell us what the volumes at UCSF are. Should we think about it as a high volume center? Start thinking about sending patients at 5.0? Where are we with the numbers at UC? Maybe I missed it.
Yeah, we are a high volume center. I'm trying to, my God, a lot of slides. It's amazing I went through all this stuff. We do about, last year we did 63. proximal thoracic aortic cases, and then this year we're on track for 72. So I think we're certainly well over sort of the 30 to 40 case cutoff in the guidelines in terms of what is considered a high volume center. And I think just as importantly, it's not just how many cases you do, but we do have a multidisciplinary team. We do regularly meet with vascular surgery. We discuss cases. And there is ongoing improvements for collaboration with cardiology as well and imaging. So yeah, I think that we should send, I mean, I think that if you have a patient that's close to 5 centimeters, it's worthwhile having them in an aortic clinic so that one, we can help with imaging, we can do consistent measurements and follow them over time.
Sounds good. Thank you.
Thank you. And then Arthi also has a question. Her microphone's not working, so I'll ask the question on her behalf. So her question is, does the need to re-implant coronaries and or age of the patient with respect to bicuspid aortic valve change your threshold to offer surgery?
Yeah, so this is actually, I didn't get into this, but one potential danger of lowering the size threshold from 5.5 to 5 as you get into the aortic root is how you handle the aortic valve. Okay, so if you have a younger patient and you intervene on their root and you replace what was a perfectly functional either tricuspid or bicuspid valve, I'm not sure you've done them any favor from offering earlier surgery, because now you've added the morbidity of a man-made, either mechanical or biological prosthesis. And there's also data from the registry, from the Titan trial, that actually the majority of root replacements that were done in these patients that are under 5.5 centimeters, they were still Bentals, meaning that these patients had valves that were replaced. If you look across the country at the STS database, about, I think, 85% of root replacements are still Bentals. It is thought that about 80% of those can be preserved. So if you're going to offer early surgery for the aortic root, you really have to consider, are you going to be able to spare that aortic valve? And that has been our practice here, to do valve sparing root replacements. There is data to suggest that doing a root replacement does not necessarily increase the risk, operative risk at high volume centers. So it doesn't change our practice very much, but I think it is a very important question. You should really intervene earlier on the aortic root. One, if you do a lot of root surgery, and two, if you're going to preserve the aortic valve, whether it's tricuspid or bicuspid.
Thank you. And I actually have, I see Dr. Benowitz too, have a question. Would you like to ask and unmute?
Sure. Thanks for the presentation. My question has to do with counseling people who are involved in endurance athletics or other sorts of exercise activities who have dilated aortas.
Yeah, so great question. And I didn't address it in the talk, but what the guidelines say is that the biggest risk is really from not so much from aerobic exercising like running, et cetera, but more from weightlifting, let's say. And they do put weightlifting limitations of 30 to 40 pounds. This is extrapolated. It's extrapolated from data from John Eleftheriades. I think a couple of decades back, they put radial A lines in med students, and they measured their real-time blood pressures as they were doing max effort squats and deadlifts and what have you. And your systolic blood pressure will go into the 300 to 400s. So then we thought, well, that's bad. So probably patients with aneurysms should not do this type of weightlifting. So we've made this somewhat arbitrary recommendation of 30 to 40 pounds. I think what it's meant to convey is that you can go about your normal life, but if your neighbor asks you to move their couch with them or what have you, that you really shouldn't go crazy lifting heavy things. But if you're a younger athlete, that's also challenging, because with significant effort and exercise, your blood pressure does go up. and that's a problem. And there have been situations where I have operated on folks that were at 4.8, 4.9 centimeters, and they were just like, look, I have a job that involves heavy lifting. I need to like live and work and what have you. And we've kind of bent the rules. And the guidelines do emphasize, it's a class 1 recommendation, that whatever you do is really a shared decision-making with the patient, and it should be taken in the context of the whole patient. So if you have a young patient who essentially cannot live their life because of this problem, we have offered early surgery. The converse is also true. There's patients that have large aneurysms that are good surgical candidates, but they just don't want to have surgery, and we continue to survey those as well. That's a good question.
All right, thank you. And I see James up here with his hand raised. James.
Thank you. Really beautiful talk. Like, just want to reiterate how comprehensive your discussion was, going back not only through the guidelines, but also kind of getting to the core of like, where do these guidelines even come from? So I just thank you for walking us through all that. Really, really nice job. My question for you has to do with Titan, and as usual, it's more of like a comment than a question, but the way that we identify people who have enlarged aortas still remains kind of by chance. Do you think that has any consequences for how we will interpret the results of Titan, even though that's a randomized trial?
Oh, interesting. Well, thank you first for the kind words. That's a good question. So, I mean, I have to think about it a little bit. I mean, certainly it is going to introduce bias in that you need to have had first access to healthcare and have had some sort of a scan in order to identify this problem. And, there are many patients who walk around, on the street without knowing that they have an aneurysm. So yes, there will be a bias, but I think it's going to be so much higher quality data than anything else we currently have that is going to be a great step forward. But yeah, I agree with you that there's going to have to be hopefully more trials and more studies to further elucidate what to do in this space.
I'll have a pitch for you for Titan 2. We can talk offline.
Sounds good. So, I mean, it is, the one amazing thing about it's really the Titan, there's a Titan trial, but they have developed a whole research infrastructure, and they're actually very open to collaborating. And actually, Elaine in particular is looking to kind of leverage the Titan registry and the CAT scans for the biomechanical analyses. So it's a very powerful network that will yield not just this Titan trial, but other studies as well. And there's also a dissection trial that's being done as part of Titan as well.
All right. Well, thank you everyone again for joining, and thank you, Marko, for a great talk, and have a great rest of your day.
Thank you. Thanks.